Thank you so much for Hello, everybody. Thank you so much for joining the Target webinar today. Today, we're going to be talking about reviewing antibiotic prescribing for patients with acne and COPD exacerbations. I can't see any of you, but I know we have quite a few people subscribed. So we're looking forward to an informative evening and some really good discussions. I'm Emily Cooper, and I'm a program manager within the Target team within UK Health Security Agency. This is our fifth Target webinar in a series we've done through the RCGP, where we'll be focusing on delayed and repeat prescribing for acne and COPD in primary care settings. The format will be the same as previous webinars. Panelists on the call will field questions through a webinar Q&A function and respond to specific questions at the end. There's a bit of housekeeping, so please ask questions throughout the presentation using the Q&A function on your screen. You don't need to wait until the end of the talk. If you wish to ask questions anonymously, please tick the anonymous box before submitting your questions. We will answer as many questions as possible in the allocated time. Speakers and panelists will not be responding to the raise hand function. We can't actually see it this evening. So do type those questions in the Q&A box. This webinar will be recorded, and the recording will be uploaded onto the Target Toolkit, and you will be sent a link with a brief survey evaluation directly after your email. It will be directed to your email shortly after the webinar. So if you could fill this out, that would be amazing, because it helps us to improve future webinars and understand what people would like to see in our webinar series. So just a quick bit of introductions to different people. I won't introduce everybody on this slide, but this is the Target and the RCGP team who worked really hard in putting this presentation together with the other folks who have been involved. A special thanks to Kath, who's worked as part of the Target team to pull things together, and Joe and Camilla as well from the RCGP. And I'd like to take this time to introduce our speakers and panelists. So we have Shazia Patel, who's a community pharmacy lead, a clinical lead at Derbyshire ICB. Alicia Lacka, a regional pharmacy and medicines project manager with NHS England. Dr. Elizabeth Beach, a regional antimicrobial stewardship lead with the Southwest NHS England. Dr. Julia Dargo, who's a GP registrar and former National Medical Director Clinical Fellow. Roxanne Memi, operations manager and clinical pharmacy technician at Equality PCN. And Supriyo Das, a senior clinical pharmacist, Equality PCN. And then Dr. Naomi Fleming, a regional antimicrobial stewardship lead for the East of England NHS. So during our time, we're going to just talk very briefly about the agenda. So we're going to talk about the background and development of the how-to booklet resources. Then we're going to go into acne worked examples and resource evaluation. We're going to talk about the PressQuick optimizing antimicrobial duration dashboard, and then go into COPD how-to resources and the development of the COPD PET, and talk a little bit of the pilot of that, talk a little bit about the pilot of the PET tool. Then at the end, we'll have a Q&A panel discussion, and we'll close promptly at 7:30, as I know everybody will be ready to hopefully head out for the evening. All right, so without further ado, I'd like to hand over to Shazia.
Thank you very much. Could I have the next slide, please? I'm going to introduce the how the resources were developed. So many of you will have seen this slide before, so I won't go into this detail, but this just sets the scene as to the importance of AMR and tackling AMR. And we know that AMR continues to be a global threat. As highlighted in the recent ESPAR report, we know that this is accelerated with inappropriate and overuse of antibiotics. In primary care, the data tells us that 80% of the antibiotics that are prescribed are in primary care, and this is from data in England in 2022. And whilst the majority of antibiotics are needed, previous studies estimate that between a fifth and a third of UK antibiotic prescriptions in primary care are either unnecessary or inappropriate. And therefore, there needs to be continuous need for reviewing our antibiotic use in line with evidence-based guidance. So if we just move on to the next slide, which will talk about what prompted us to focus on acne and COPD. This was based on data intelligence, which showed that COPD and acne after UTI and splenectomy were the most common indications for the long-term and repeated antibiotic usage. In 2022, doxycycline and lemmacycline were the second and third most commonly used long-term and repeat antibiotics in primary care. And an audit of antibiotic prescribing during COVID-19 pandemic across English primary care network found that antibiotic prescribing was in line with national and local guidance in only 28.7% of cases. So we know from this that there is a fundamental question as to whether repeat antibiotic prescribing as routine in primary care is actually effective and safe for the patient. And there is limited evidence for the effectiveness of this practice, whilst there are signals of risk of use of antibiotic frequently over time. So that was the data that prompted the development of resources focusing on acne and COPD. So if we just move on to the next slide, we'll just show you on the TARGET Toolkit where these resources can be found. So on the RCGP website under TARGET, there is a section of Antibiotic Toolkit Hub, and the two resources are located here, along with some worked examples, which will be talked about a little bit later, and after I have continued to discuss how the resources were developed. So could I have the next slide, please? So we know also that their general practice has time constraints in terms of the time given for consultations. And we also know that there was an increase of online access to online providers, which sort of increased exponentially during the pandemic. And this has given rise to increased access to providers that potentially are not registered in the UK. So there's a safety concern around accessing medication online. So what we did is we did a role play of a typical consultation, which led to putting together a one-stop resource package that will give some background of the indication, background for AMR, and is set out in a sort of similar or same format for both of the resources to cover information for primary care teams, including information on the condition, aggravating and modifiable risk factors, and a in-practice guidance around a QI tool to improve prescribing within the practice. So some searches in there for EMIS, System 1 and Vision. And then it moves on to talking about how to conduct a structured medication review. There is also in the resources referral criteria and some self-help resource links, and a link to digital apps which can help to support the conversation with the patient in terms of how the treatment is being successful or not. And often these are difficult conversations, but it's easier for a young person to see in the instance of acne how their condition may be improving or not worsening if they've been taken off an antibiotic. So that kind of sets out the format of the resource. If we just go on to the next slide, I will just talk you through a visual illustration in the tool that brings together the elements of structured medication review. And we know that this is part of the PCN Direct Enhanced Service, which includes, this just gives a visual really on the elements of that. So the shared decision-making element, ensuring that personalized treatment, including the impact on the quality of life, and the key safety and effectiveness criteria. So the information set out within the how-to guide supports that conversation to cover all those elements within that consultation. So that gives a run through as to how and why the resource was created. So I will now hand over to my colleague, Alicia, who will discuss some of the worked examples to supplement the resource. Thank you.
Thank you, Shazia. Next slide, please. So why should we review patients on repeat and long-term antibiotics for acne? So we know that acne is a common skin condition and it's frequently treated with oral antibiotics, which are limacycline, doxycycline, and these are both broad-spectrum antibiotics. So research has highlighted the growing concerns of antibiotic resistance in the treatment of acne, and prescribing patterns suggest an overuse of antibiotics in patients with acne. A study in 2022 showed that 44.5% of people with a new acne diagnosis received a prescription for long-term antibiotics. And in addition to this, we know that the prescribing of antibiotics for acne is not always in line with NICE guidance. So there have been studies looking at the prescribing patterns, and they found that the most common prescription given in an initial acne consultation was for an oral antibiotic alone, which is against NICE guidance. So therefore, we really do need to review antibiotic use and reduce unnecessary exposure to long-term antibiotics. And in terms of stepping down antibiotics, we know that the conversations with patients about withdrawing acne antibiotic treatment have been deemed difficult and sensitive. So stepping down antibiotics does need a stepwise approach, and the how-to toolkit does support having those conversations with patients. We should also be mindful of the risks of inadequate management, and these include permanent acne scarring and hyperpigmentation, the emotional impact that comes, and the mental health distress, and the access of online treatments from unregulated providers, which may cause risks to patient safety. Next slide, please. So we want to introduce you to the Target Acne How-To Worked Examples resource. And this was developed to be used alongside the How to Review Acne Toolkit. And it can be used by medical prescribers, non-medical prescribers, and pharmacy professionals to review the clinical management of patients with acne. So there are 3 worked examples that we've included in here, and each of them takes you through a structured stepwise approach, patient-centered approach. And the scenarios include those patients that are currently on antibiotic treatment, those patients that require referral, that have dark skin and hyperpigmentation, and those that require stepping down of treatment. Next slide, please. So each worked example starts with carrying out a patient-centered review, and this table covers the points in that review. So looking at condition and consultation history, establishing the history of the patient's condition, their baseline habits, any lifestyle modifications or treatments they may have tried, and whether they are under a specialist consultant. Also looking at their treatment history, what are they currently being prescribed? Have they had side effects to treatment? What's their compliance like? And how does the patient feel that their treatment is working? And it's also really important to explore the impact that this condition has on their self-esteem and mental health. So listening to the patient's concerns and priorities and establishing their expectations for management of the condition. It's also important as a special consideration to consider those with darker skin tones. So post-inflammatory hyperpigmentation can be more marked. So therefore, you may want to consider earlier consideration of referral to secondary care or dermatology service. Next slide, please. So using the responses from the patient-centered review, each worked example goes through how to manage a patient with acne using a stepwise approach that incorporates treatment and referral, patient education, self-care advice, and follow-up reviews. So where you want to treat the patient, whether you want to initiate, stop, step up, or step down treatment, or whether you want to consider the need for onward referral to mental health teams or secondary care. Self-care advice, so using there are useful resources and apps, and also giving advice on skincare and dietary advice as well. Making plans to review the patient, so reviewing antimicrobial therapy at 12 weeks, using photos to track progress, and considering whether they need another 12 weeks of antimicrobial treatment. And educating the patient is also really important, explaining to them what to expect, the importance of compliance, how long it takes for the medication to actually make a difference, and the importance of completing the course as well. Next slide, please. So UKHSA, NHS England, and the University of Nottingham, we did a collaborative study, and we looked at evaluating the how-to resources by pharmacy professionals. And we developed surveys that were based on the COM-B model, so capability, opportunity, and motivation. And these surveys were sent out to GP practice and to community pharmacy. So in GP practice, we had around 141 respondents that completed the surveys. And the use of the Acne how-to resources, it was found that it led to increased capability, opportunity, and motivation, and overall deemed useful to support pharmacy professionals in GP practice. And the respondents also fed back that they found these resources good use. There was good use of advice for different types of skin color. These are exactly the sort of resources required for pharmacy technicians to be able to carry out reviews. And many respondents did feedback that they found the resources very informative. In community pharmacy, we had 44 pharmacy professionals and 10 stakeholders respond to the survey. And overall, it was deemed that the Target Acne how-to resources supported pharmacy professionals in the management and review of antimicrobial treatment for acne. And there were potential future roles that were identified in managing acne, such as reviewing long-term and repeat prescribing. And these were alongside needs that were identified, such as training, development of PGDs, and remuneration. And just to also add that the use of the how-to resources does support the UK's 5-year National Action Plan. Next slide, please. And this takes us nicely into looking at community pharmacy. So the NHS England Independent Prescribing and Community Pharmacy Pathfinder programme has a central aim to support and test different prescribing models to help inform and develop the framework for the commissioning of independent prescribing as part of clinical services in community pharmacy. So this service is the first to nationally fund pharmacists to use their IP qualification. And it looks forward to 2026, where all newly qualified pharmacists will be independent prescribers from the point of registration. So there are 2 Pathfinder sites that are undertaking acne review as a clinical model. And this really gives us the opportunity to see how acne can be managed in a community pharmacy setting, and also the potential for future joint working between GP and community pharmacy through a joint system-wide approach. And I shall hand it over to Elizabeth.
Thank you, Alicia. Good evening, everyone. I work for NHS England, and one of the work streams I lead is data for improvement for the duration of antimicrobial use. And along with Prescrip, who host the antimicrobial duration dashboard, we have developed a set of metrics for use with primary care prescribing data. And I'm going to talk very briefly about this tonight. Next slide, please. So just to put that into context, as you're very well aware, we have a UK 5-year National Action Plan. And within this, one of the ambitions, or a number of ambitions actually, are pinned on optimal use of antimicrobials in humans. We have some measuring success targets, one of which is to reduce antimicrobial use in humans by 15% by 2024. We've spent a lot of the last few years focusing on reducing inappropriate prescribing of antimicrobials, but now we are extending that focus to include a focus on where antimicrobials are prescribed, ensuring that the duration is appropriate and as short as possible. Next slide, please. So before I talk about the metrics that are in current use, I wanted to talk a little bit about the exploratory work we're doing with trying to develop a metric that we can use for acne. And this would be looking at optimizing the duration of oral limecycline in people with acne. Slightly different to our other metrics because, of course, this is a repeated prescribing situation. It's effectively like a long-term or a medium-term condition rather than a single acute infection consultation. So there have been some challenges with how we do this using routine data. But the process that we have used is the process we've used for all of our metrics, which are very much pinned on the NICE guidance. So the NICE guidance for acne places oral antibiotics, both limecycline and doxycycline, in moderate to severe acne. We're looking at limecycline for a metric for acne because it's really got very little use anywhere else. So we can use the routine data fairly confidently that it is being used for acne. The metric that we have built up is a people metric because we've needed to use linked data. And so working with the NHS Business Services Authority, who published the EPAC2 dashboards that we have identified the number of people in the last 12 months to August 23 who were prescribed limecycline at least once. And that was about 65,000 people in primary care in England. And then we have been able to link that, that prescribing activity to each of those 65,000 people and identify the number of limecycline days of therapy effectively that they have received. And this has allowed us to create our metric, and our metric therefore reports the proportion of people in scope who have been prescribed limecycline for less than 12 weeks, which is the light green, and that's about 20% or just under 20% of this population. The proportion of people who've had limecycline for precisely 12 weeks, and then for more than 12 weeks but less than 24 weeks. NICE recommends a 12-week course of oral antibiotic. If that's been effective, stop. If that's partially effective and the patient's acne is improving, then maybe consider continuing for another 12 weeks. But once you get to 24 weeks, then NICE recommend a stop oral antibiotic use. So what we can see is that current primary care prescribing of limecycline, nearly about 45%, nearly half of that is for longer than those 24 weeks. So clearly there's a lot of inappropriately long prescribing of limecycline in this population. Next slide, please. As with all of our other metrics, which I'll talk about in a minute, we report the metrics in our dashboard from England level all the way down to GP practice level through an ICB. And so as this is as an exploratory metric, we just report to ICB at the moment because we're looking at does it hold up and what's the extent of variation. So this is the data for the same time period, the same 65,000 people over the 42 ICBs, and you can see there is a lot of variation, but there's still a lot of 24-week plus duration prescribing activity. Next slide, please. So I mentioned the Prescrip Optimizing Antimicrobial Duration Dashboard. Prescrip have been a partner working with NHS England supporting the AMR programme since 2015. The dashboards that we co-produce are open access. You do not have to be a registered Prescrip user, and the link is there on the slide. So please do go and have a look. We currently have 3 dashboards with Prescrip. And this dashboard has recently been amended for those of you who are used to using it, because we now have 4 metrics in routine reporting, and you can see those there: amoxicillin 500 milligram capsules, doxycycline 100 milligram capsule, flucloxacillin 500 milligram capsules, and PenV has just been published. And we've now had to move to single dashboard reporting because of the volume of data. In each of these dashboards, they're formatted with the same sort of colors and the same auto report. So it's very, very easy to jump between one or the other. And the way that we develop the metrics is consistent across all of these antibiotics. Next slide, please. So the metric development is based on some criteria. The first is high volume of antibiotic prescribing. So amoxicillin is the highest volume in terms of prescription items, antibiotic prescribed in primary care in England. Very briefly during the pandemic, it was overtaken by nitrofurantoin, and that was because of a reduction in use by children. Secondly, we have to have robust NICE guidance for both dose and duration on which to base the duration. And for amoxicillin, that is 500 milligrams orally 3 times a day for 5 days for most of those prescribing guidances, and you can see the list of NICE guidances in the middle of the slide. It also needs to be an AMR programme priority workstream. So in the case of amoxicillin, for example, we know this is a driver of E. coli resistant infections and resistance, and so this is an extra priority for us, that we minimize unnecessary duration of use of amoxicillin. And lastly, we have to be able to define smart metrics using routinely reported data sets. So for amoxicillin, this is actually very simple. We use quantity 15 and quantity 21 from the EPAC2 data. Worth noting that EPAC2 data does not report an indication, so we do not know what the indication is. And then when you get onto the metric for doxycycline, then it becomes a bit more complicated because you have to have, some judgment call there. But that gives you some insight into how these metrics are developed. Next slide, please. So if we look at amoxicillin as we move into COPD from the next speaker, you can see here, this is the September 2023 single month view of the proportion of amoxicillin that is prescribed as 5-day, which is the green, 7-day, which is the turquoise, and other day, which is the purple. And again, I've chosen to show the slide of ICB level performance, and you can see there's large variation, and this metric's been running now for about 6 months, with Leicestershire and Nottinghamshire who are hitting about 75% of all amoxicillin 500 milligram capsules prescribed as 5-day. And I'll hand over to Julia.
Thank you so much. Good evening, everybody. I'm Julia Darko. I am a GP registrar. I am very passionate about primary and secondary prevention in general practice, and I worked as part of the NHS England AMR team, and I'll be talking you through the COPD side of things this evening. So next. Okay. Why COPD? Well, the focus on COPD has really been brought about the fact that this patient cohort represents a large selection of the population. It is a very commonly diagnosed chronic disease, which does affect over 1 million people and contributes to over 30,000 deaths per year. It also has implications for patients' quality of life, their function, their exposure and overexposure to antibiotics and steroids. And also frequently we see this patient cohort significantly accessing urgent or primary and secondary care as a result of COPD exacerbations. So really an ideal cohort to target secondary prevention mechanisms. Next slide, please. This is how to use, right? So the how to, I really want to amalgamate some of the within recommendation and really this information in one extra helpful document to support primary care team review patients that require antibiotic treatments for COPD. And the idea is providing an evidence-based strategy to reduce exposure to antimicrobial. It is really at
Julia, your voice is breaking up. Sorry to interrupt you.
Sorry about that. Can you hear? Is that all right?
That's better. Thank you.
Better? Okay. So really.
Oh, sorry now, Julia, we've completely lost you. We've lost you, Julia. Can you adjust your microphone again?
Emily, if we can't get Julia back, would you like me to carry on?
Yes, please, if you don't mind.
Yeah, that's fine. So the How to Review COPD Prescribing Toolkit and the How To series is basically distills down the prevention of exacerbations of COPD and the treatment of exacerbations and how to review that treatment in a 23-page document as opposed to a gold document and NICE guidelines, which are hundreds of pages long to sift through. So that's the aim of this. This flowchart gives you the idea of how to go about reviewing these patients. And you can either do that through ad hoc, when you see a patient and you think that they need a review, or you can do a population health approach and actually undertake a search and analysis to identify patients who've had a repeated use of antibiotics, either through rescue packs or acute prescribing. And then following a practice audit type approach to call those patients in and review their medications in pre-planned clinics. Next slide, please. So in terms of a patient consultation as part of the how-to toolkit, it's really important to establish that clear patient history. How often are they exacerbating? Are they using their rescue packs correctly? How does it impact on their quality of life in relation to their condition? Can they do their hobbies? Can they do their job? Do they get breathless climbing the stairs, etc.? We need to confirm previous optimization of non-pharmacological interventions. So have they stopped smoking, for example? Can we support them with smoking cessation? Can we make sure that they're up to date with their vaccinations? Can we also think about other interventions such as pulmonary rehab, losing weight, those kinds of things to absolutely optimize their non-pharmacological interventions. Signposting to digital apps is quite useful, and other resources, making sure patients are using their inhalers correctly and are concordant with their medication regime is really important. Then discussing with patients the expectations on antibiotic use, what the rationale is for using antibiotics, when they should actually be just increasing their short-acting beta agonists, when they should be using steroids alone, and then only adding in the antibiotic where it's indicated in their self-management plan. And then we can, if we need to refer, we can, and this is really important for spirometry if COPD has never been properly diagnosed, but also referral to secondary care services where required, or mental health services as well, if patients feel that they are suffering with their mental health through COPD, or if actually anxiety is impacting on breathlessness, and that is then getting treated as COPD. Next slide, please. So why develop the COPD Prevention of Exacerbation Toolkit? So the how-to resource was 23 pages long, and it does take you through quite a lot of the information. But actually, when you sit down with a patient, you don't want to be looking at a 23-page document. So what has been developed once you have actually used the how-to guide to think about how you're going to manage these patients is a checklist. And this is a document for primary care teams to work through with their patients during the consultation, to act as an aid memoir, to make sure that all the steps have been considered, and then all the referrals are done after that consultation has taken place. It does also have links in there to self-care management plans and examples of things that you can discuss with your patient, as well as to things like the MRC score. Next page, please. So this is it in a nutshell. So this is a COPD PET tool, which stands for COPD Preventing Exacerbations Toolkit. And it just goes through, has your patient had that spirometry? What's the patient's own account of the impact of the condition on their quality of life? What is their MRC breathlessness scale? What is their understanding of their diagnosis? And there's a patient leaflet link there. Ask your patient what they can do themselves to manage their condition better. Have they identified any triggers that they can avoid? Have they even thought that there might be triggers that they can avoid? Can they stop smoking? Can they lose weight, for example? Do they know what to do in the case of a flare-up? And they have a link to a patient leaflet there. Discuss patient flare-ups and discuss antibiotic use. Was it appropriate? Was it not appropriate? And in particular, if a patient is prescribed long-term prophylactic antibiotics, are they actually having an effect, or is that patient still exacerbating? And please confirm as well they're a non-smoker or ex-smoker, because long-term antibiotics have a lack of efficacy in smokers. And then talk to them about the benefits and risks of antibiotic use, and trying to make sure that they're only used appropriately. Think about precautions to avoid exposure. Think about better diets and exercise. Review vaccination status, make sure that the patient has got all the vaccinations they are recommended to have. Smoking cessation, we've mentioned it several times, but it is really key. Inhaler technique, making sure that the patient's inhaled pharmacotherapy is optimized. Can they use that particular type of inhaler? What is their technique? Do they need a spacer? Could they be swapped to a dry powder inhaler? Could we tackle the greener agenda at the same time? And can we often refer to local pulmonary rehabilitation services who have been proved to reduce exacerbations in these patients? Once you've discussed all this, you can make a clear action plan and you can give that to the patient, and then you can check in with them in 6 months' time and see how they're getting on. Next slide, please. So during a general GP consultation, someone might come in and say that they are breathless and coughing up green and nasty sputum, and you might confirm the diagnosis of an acute infective exacerbation and treat. Lots of exacerbations can be treated without antibiotics, but if you do want to prescribe an antibiotic for COPD for an acute exacerbation, we normally recommend, or nice first-line treatment is amoxicillin 500 milligram 3 times a day for 5 days. But during that consultation, you might realise that actually your patient does need a COPD review. They might not have been for their last annual review. They might not have reordered a spacer, or they might not be able to show you their inhaler technique very well. They may have had a couple of COPD hospital admissions, or they may never have had pulmonary rehab. So at that point in time, you might decide that this patient needs to have an in-depth COPD prevention of exacerbation toolkit review, and you can refer to your appropriate team that conducts those reviews within your practice. Next slide, please. So I'm going to pass over now to our team that have been piloting this COPD prevention of exacerbation toolkit, so that they can talk through their experiences of using the toolkit, their feedback from patients, and their own feedback on how they've felt using it and what they've learned from it. So thank you to Roxanne and Supriyo, passing you on now.
Thank you. Hello, I'm Roxanne. I'm the Operations Manager and Clinical Pharmacy Technician for Equality PCN. And with me is our Senior Clinical Pharmacist, Supriyo. Together, we were fortunate enough to be approached to participate in this project. And we're here this evening to give you an overview of our experience of the preparation and delivery of the COPD PEP pilot. Next slide, please. So a little background about the pilot site. This is our organisation, Equality PCN. We're one of 5 PCNs in Luton, and we serve just under 40,000 patients over 4 sites. Luton, for those who are not familiar, is a very diverse and densely populated town with over 150 languages and dialects spoken. It has a younger than average population, but a high level of unemployment and deprivation with high levels of child poverty. Next slide, please. So preparation for this project, it was broken down into the outlined areas on the slide. But we firstly identified our patient base, and we managed to achieve this by extracting data from a recently completed prescribing incentive scheme audit, which identified patients with a very similar criteria. Once we'd exhausted this list, we conducted a manual search, which was created across the 4 sites. We then focused on patient engagement, and this included contacting patients directly by telephone to book, and that really was to improve greater attendance. We also considered barriers that were specific to this cohort. So, and a good example of that was that we tried to book ground floor rooms only where possible. We also booked a peer discussion, which we'll go into in a bit more detail on the next slide. We began identifying our own learning needs as clinicians and gaps in our own knowledge, and we familiarised ourselves, of course, with the actual COPD PET tool itself. We included our IT support lead, who kindly assisted us in developing a more tailored COPD PET template on System 1. And we agreed upon an in-house referral pathway as well to some of the areas sort of previously spoken about, spirometry, pulmonary rehabilitation, social prescribing, and the stop smoking service. Next slide, please. So our peer discussion, as you can imagine, we had lots to discuss as we were really keen to involve some locally agreed additions to the COPD PET toolkit. And that was really so that we could fully utilise the time that we had face-to-face with patients, but also the skill set of the clinicians that were involved with maximum effect. So this included a crossover with CBD DES, and we also made sure that we use the InCheck device as well to check inhaler techniques. And that allowed us as well to optimise the patient's medication at the time of the appointment where appropriate. Luckily for us, Ciprio is an independent prescriber, and that obviously enabled us to be able to deliver this. The patients were then booked for follow-up reviews if there had been any medication changes. We decided to complete these ourselves for continuity of care, but we do recognise that a new medicine NMS service offered by community pharmacies could have been utilised at that point. We also got to grips with the educational literature that we were supplying to patients and how to complete COPD care plans as well. And that was so that they could be provided to the patient at the time of the appointment for a very smooth, efficiency during the consultation. So over to Ciprio.
Thank you. And next slide, please. So after our peer discussion, we decided to put the actual PET checklist into action. And we started our consultations, and basically the PET checklist allowed us to form a kind of easy introduction to the consultation, allowed us to gain a thorough respiratory history, and we understood sort of the condition and how the condition actually affected the patient's quality of life. Then the checklist directed us to easy to read educational material for patients to use to understand their condition better. It encouraged a holistic approach and it empowered patients to take control of their condition. Then we moved on to sort of detailed discussions regarding vaccinations if patients were hesitant, and Roxanne completed specific training in this area. We recorded MRC scores, saw sort of smoking histories as well. We discussed exacerbation histories. We explored when patients would use their antibiotic and steroids for exacerbations and provided sort of education on this. We highlighted the risks of antibiotic resistance and sort of side effects. And we holistically provided lifestyle advice and referring to services to help support this patient, as mentioned previously. We took clinical examinations, then we moved on to reviewing the respiratory medication, assessing the adherence to their treatment and providing education on how that medication works for that patient. And we reviewed their inhaler technique using the InCheck dial device, and where appropriate, we would optimize their therapy and arrange follow-ups as well. Next slide, please. So brings us along to a typical patient we reviewed in one of our clinics. So a frequent exacerbation history over the last 12 months with one hospital admission. They last had a COPD review in 2019. There was no sort of noted spirometry on their records to confirm their COPD diagnosis. They were an ex-smoker. They had a high BMI. They declined flu vaccination, and they currently were on Anaro, Ventolin, and carbocysteine as their therapy. Next slide, please. So during the consultation, we ascertained that their MRC score was 3. They lacked confidence with their exercise due to their condition. We encouraged benefits of exercise for weight management and strengthening their respiratory muscles. We agreed referrals to weight management services and a social prescriber input in regards to the exercise classes. We highlighted the benefits of pulmonary rehabilitation and referred them. And also refer them for a spirometry to confirm their diagnosis. We addressed the vaccine hesitancy and we booked them in for a flu jab. The patient lacked awareness on when to use antibiotics or steroids to treat the exacerbation. So the patient admitted to taking antibiotics sort of hastily to prevent an exacerbation for longer than the recommended duration. So amoxicillin for 7 days rather than the recommended 5 days. So we highlighted the risks of antibiotic overuse and provided patient leaflets on how to treat an exacerbation and the signs of when to treat an exacerbation. We reviewed their inhaler technique. The technique was suitable for a dry powder inhaler and they had good adherence. So due to their multiple exacerbations and their MRC, I felt it was appropriate to add in an inhaled steroid. So we changed their therapy from the Inaro, which is a LAMA, to a triple therapy trilogy. And we provided them with a thorough COPD care plan. And also a follow-up was booked to see how they're getting on with their new inhaler. Next slide, please. So doing many of these consultations, we learnt quite a lot from there. There was a lack of spirometries to diagnose the actual condition, and they potentially maybe overlapped with our conditions such as cardiac failure. The impact of COVID caused less sort of face-to-face COPD reviews, which we believe made patients more vulnerable to exacerbations and poorer control of their condition. And sort of the patient knowledge was quite lacking on the condition and how to actually use their actual antibiotics and steroid rescue packs. So providing a comprehensive review with shared decision-making and a holistic sort of mindset will hopefully lead to reduced sort of GP consultations, better attendance for future COPD reviews, fewer exacerbations, less hospital admissions, and better control of their COPD. Next slide, please. So with each patient that had a consultation, we offered them a chance to feedback on whether the service was appropriate for them or whether they felt it was beneficial. We had 30% of patients responded to the questionnaire. 100% of those patients felt very involved or extremely involved. And 90% of those patients would recommend the service to their family and friends if they needed similar care. So it was mostly positive. I believe they liked the patient-centered review where we gave them enough time to discuss the condition and the impact on their quality of life. I believe that patients found benefit from sort of the education provided on the role of antibiotic usage and when to actually use the rescue pack. Next slide, please. So in regards to a follow-up, we would do a 6-monthly follow-up, a 6-month follow-up and a 12-month follow-up. And with those follow-ups, we would record their MRC score, their smoking history, the exacerbation history and their weight. And that will show us whether the consultation was beneficial for them. The results will be shared with sort of key team members. And once the pilot is complete, the COPD PET will be published in the TARGET Toolkit, and further resources to support staff training on COPD will be developed, such as the slide sets and worked examples and a video consultation as well, an example there. So if your practice is interested in piloting the COPD PET, please contact Naomi on the email that you can see there. And if you're interested in joining the community of practice for antimicrobial stewardship, again, please contact the email you can see there on the slide. Thank you. Over to you, Emily.
Thank you so much, everybody. So we're coming towards the end of the webinar. I just like to put this slide up to share the names of those we need to acknowledge. Some of those actually we need to acknowledge who've been working on this project as well as the webinar. So a big thank you to all those who provided support to pull this together. And then just a reminder to please complete the feedback survey and let us know what topics you would like to, it will give you an opportunity to let us know about what other topics you'd like to hear about. Also to let us know how we've done this one and how we can improve. We have 2 more webinars coming up. One is going to be around antibiotic management of respiratory infections. That will be focusing on cough and acute sore throat in January. And then another one around UTI in March. And you can go to the Target Toolkit page to find out more. And so I'd like to go ahead and move over to the panel discussion component of our talk today. We don't have a lot of time, but hopefully we can get through some of the key questions that have been asked. I'm going to stop sharing my screen, and if all the presenters could please put your videos on so we can see all of your faces. Thank you. Great. So my first question is going to be actually for Elizabeth and Alicia. Someone has commented, it's interesting to see the variation in 5-day amoxicillin metrics across regions. Do we know what initiatives are being undertaken in the regions with the high proportion of 5-day duration to encourage shorter durations? Perhaps we can learn from them. So if you, Elizabeth and Alicia, if you'd like to take that one, please.
Yeah, absolutely. So 2 things. First of all, yesterday we held a great webinar with PressScript with the AMS virtual professional group. So if you would like to join that group, if you go to that PressScript link that was in my slide during the presentation, you will see there's a way to join that professional group. And we hold quarterly webinars on all sorts of really interesting things to do with antimicrobials. And within that, we had a lot of shared learning from Nottingham, for example, who are leading the way, but also from Devon, who've done some very rapid improvement, and from BNSSG, and from the Southeast region, who, as a regional team, have identified optimizing duration as a priority. And they have developed some useful resources, which include some myth busting around the evidence about is 5 days safe or not. Also some infographics to help remind clinicians which antibiotic should be prescribed for which duration. And I think Alicia's going to be putting the links to where to find those in the chat. They're hosted on the Future NHS Workspace that the AMR programme hosts. So you will need to join that workspace to access those resources. And if you do join the PressScript VPG, then you'll be able to access a recording of that virtual professional group meeting yesterday. But the sorts of things people were doing were using the PressScript data because it drills down to GP practice level, so it shows the variation in your own system. And as someone said yesterday, a bit of healthy competition never did anyone any harm. You can use, if you're a System 1 user, you can position your quantity 15 amoxicillin at the top of the pick list. For example, you can use your clinical decision messaging system if you have ScriptSwitch or you have OptimizeRx to put messages on. If you are a ScriptSwitch user, then you can actually launch that message when a quantity that isn't 15 is prescribed. In other words, a 21 quantity, 7 days prescribed. You can't do that with OptimizeRx, which means everybody who prescribes amoxicillin gets messaged, but you can pulse the messaging, for example, at smart times of the year, like high respiratory tract infection prescribing that we inevitably get in January. Incentive prescribing schemes have been used very successfully by providing targets or improvement proportions within that, newsletters, and reminding people that everyone's local guidance does actually recommend 5 days of amoxicillin for most respiratory tract infections, but maybe people just had not had a look at them lately. Alicia, I'm sure I've forgotten something. Would you like to add in what I'm sure I've omitted something useful?
No, I think you've covered most things. I was just going to add in about our evidence bundle for shorter course lengths that's on Futures NHS. So we're talking about amoxicillin, but in the evidence bundle, we talk about the common infections in primary care and reinforcing you know, the 5-day prescribing and appropriate durations in line with NICE guidance. And there's some useful infographics there that you can also use to share in your practices and have that part of your implementation plan. In the evidence bundle, there's some quick wins about how you could implement shortest effective courses as well. So similar to what Elizabeth was saying, enabling script switch, making sure your IT system allow you to be able to choose the 15-day pack rather than the 21-day pack. So really, if you haven't managed to look at it, please do. It's on Futures NHS, and we'll get a link put in the chat for you as well.
Great, thank you for those responses. My next question is actually for Naomi. Naomi, someone's asked, how can we find the COPD PET toolkit? It's not available on Target yet. So where can we find it, and maybe when?
No, it's still in the pilot phase. So Supriya and Roxanne are doing a fantastic job of piloting this for us and may make some recommendations for change. But if you would like to have a preview, or you want to have a go at it in your practice, and you are keen to just have a look at the tool, if you email me, I am very happy to send it out to you to have a look at, pilot in your practice, or even just have a chat.
Great, and someone's asked for your email, Naomi, because we couldn't get it through. I think what we can do is we can if you email Target, we can send your details. If you email them asking for your email because they want to be involved in the toolkit project, email us and we'll send Naomi's details to you. Okay.
Yeah, and I have put it in some of the answers, so hopefully people have received it in the answer Q&A.
Thank you. Thank you very much. All right, my next question is actually for Supriya and Roxanne, and it's someone asking about how long on average it takes for the COPD PET review per patient.
So we started 45 minutes, but actually we soon realised that was too lengthy. Realistically, it could be completed in about 25 to 30 minutes, but of course we added in sort of locally some additions as well, so you wouldn't necessarily need to put a blood pressure and so on in there. So it would depend on what you wanted additionally from the consultation, but the actual PET tool itself you could probably complete in about 25 minutes.
Brilliant, thank you. That's great to know. And then a question for Elizabeth. It's about the limacycline duration data available on Prescript. Is it available on Prescript, and if so, where can it be found?
So no, it's not yet, because it's still an exploratory metric. But we will be working with Prescript. We've just got agreement to do this to hopefully get it up in January. So it will join that same dashboard, which has got the other 4 metrics on, in a very similar format.
Brilliant.
Can I just add one extra comment I forgot in terms of support and help for the optimizing duration work stream? And please do use your regional antimicrobial stewardship lead from NHS England. There are 7 of us, and you can find the contact details for your region. Their contact details are posted on that Prescript AMS hub, so they're really accessible.
Thank you. I think maybe one or two more questions. This one might be for Shazia or Alicia. Could a pharmacy technician carry out the acne and limacycline audit with clinical support?
Well, I mean, I think that there's opportunity and potential to use the whole pharmacy team, whether that be in community pharmacy or in the practice, and working as a sort of at PCN and practice and community pharmacy level, that sort of like community of practice approach. There is various elements in the resource that would allow that sort of some of that support. So the baseline audit, identifying the patients, some of the self-care, signposting people to the digital app, that sort of thing could be done by a pharmacy technician.
Yes, absolutely, I agree. And when we did the survey and we asked pharmacists, we collected the responses from pharmacy technicians, we found that pharmacy technicians were already doing interventions when it came to reviewing patients with acne. So certainly using the target resources, using the Acne How to Review Toolkit and the worked examples, there's no reason why a pharmacy technician, a trained pharmacy technician, cannot carry out those clinical reviews, even the patient-facing reviews as well.
Great, thank you. And I'm afraid that's all we have time for, but those of you who've put comments in, we will be publishing the Q&A responses. So we'll respond to your comments, and then those will go on the Target Toolkit alongside the recording of this webinar. It will be linked on the toolkit so you can watch it in the future or recommend it to your colleagues. So thank you again, everyone, so much for your support and the participation. And yeah, I hope everybody has a very good evening.